Hello and welcome to the latest episode of the Partially Sighted Society podcast, where we bring you insightful conversations, expert advice and uplifting stories from across the sight loss community and beyond. In this episode, we're absolutely delighted to be joined by a very special guest, Mr. Dinakaran, an esteemed ophthalmologist specialising in retinal care at Doncaster and Bassetlaw hospitals. With a wealth of experience spanning many years, Mr. Dinakaran has dedicated his career to helping people maintain and improve their vision, and has been at the forefront of some incredible advancements in eye health and retinal treatment. We were incredibly fortunate to welcome Mr. Dinakaran to our sight centre here in Doncaster, where he sat down with us for a fascinating and in-depth conversation about his work, his journey into ophthalmology, and the life-changing impact of retinal care. So, whether you're living with sight loss, supporting someone who is, or just curious about the remarkable work that goes on behind the scenes in eye care, this conversation is one you won't want to miss. So, settle in and enjoy our chat with a brilliant Mr. Dinakaran. So Dina, can you tell us a little bit about your role and what you do as a retinal specialist?
The role of retinal specialist probably is something in the last 20 years or so. I think when I trained as a doctor to become an ophthalmologist, the place where I trained, they did have individual subspecialties, but that wasn't very common. I'm talking about late 80s, early 90s when I did my training in India. Even though the subspecialty existed, but most ophthalmologists did everything. The initial years when I came to this country in 1990, pretty much I did everything. I did squint operation, eyelid operation, drainage operation, glaucoma surgery, cataract surgery, and retina. In those days, retina, the intervention that we did was mostly one thing, which is laser treatment. And AMD, which is one of the top eye conditions now for visual impairment for elderly, didn't even have any treatment available. So you literally more or less threw your arms up in the air and sent to patients, unfortunately we can't do anything, you've lost your vision. So the specialization came in from the inspiration I got during my early years with my senior colleagues here, and then moved on to Sheffield to do my specialist training. And I had a mentor who had an interest in, he was a very passionate man. So then I said, this is my field that I will be going in. So that's how it came on. But having said that, even though I'm a retinal specialist and I have colleagues, we deal with everybody because we are on call and we deal with all conditions. But so that we allocate the specialist in that area to deal with, we keep moving patients from one to the other. But for practical purposes, we have to be general ophthalmologists first with interest in retina.
That's excellent, yeah. So you mentioned about your mentor. What initially drew you to the field of ophthalmology then? What was it?
That's an interesting thing, actually. I don't know how training, you're aware of how the training used to be. So when I was a medical student, I joined in 1978, that was my first year in medicine. There were only three major specialties: medicine, surgery, and gynae. So those were the big specialties, and all of them were put into it. The little specialties, they were there even then. The ophthalmology school in the place that I come from, the second oldest in the world after Moorfields. 1910 was, I think, 1908 or 1910, the Madras School of Optometry or Ophthalmology. But ophthalmology was not very developed technologically. You just had a torch and a loop magnifier, you examine them. And as medical students, we spent 2 weeks. It's no different now.
Really?
It's no different now in the UK. It's actually worse. They used to spend a week with us as medical students. Now it's just 1 day a week. Can you believe that?
Ophthalmology?
Correct. One day a week.
As a medical student?
Correct. And that could even be half a day a week if they had something else taken over.
What is the reason for that?
I don't know. I always wondered why that is the case. 10% of general practice will be patients with eye problems.
Yes, yeah.
It's such a small part of the body, but it's just got so much.
So much. It's a tiny organ. literally, sometimes you do, are you a diabetic? Oh, suddenly you say, how do you know? That,
That's it.
do you have high blood pressure? So, the terminology, eyes are the windows to the soul.
Yes,
Yeah.
yeah.
Eyes are the windows to your health.
Yeah.
It's
Absolutely.
absolutely
Yeah,
true. But
absolutely.
I found it bizarre that when I was a medical student in the late 70s and early 80s, I spent only 2 weeks observing doctors doing ophthalmology.
Wow, that's
It became
unbelievable.
1
That
week
is.
here, and now it's just 1 day a week. So the way I got into ophthalmology was by chance, you can say, in a way. As every medical student, people will think, I want to be a surgeon, I want to be a physician, or I want to go down the obstetrics and gynecology route. So for me, I wanted to be a surgeon. And because of the way the training is designed, that I had 180 medical students in my medical school where I come from, and there would be only 2 seats per year for general surgery.
Oh, wow.
So that means
Sure.
Competition.
Yeah.
competition is crazy.
Yeah.
So it would be very difficult to get into. So, but still many people pursue, they do their practice and then carry on. So then I learned about the top medical school in the country, which is funded by the national government, called All India Institute of Medical Sciences. And they had a separate 5-story building just for ophthalmology called Dr. Rajendra Prasad Center for Ophthalmic Sciences. That's named after the former president of India.
Wow.
And they were just doing only ophthalmology.
Yeah.
And then I thought, okay, but it meant that I had to go 2,000 kilometers north from where I live
Oh, okay.
to actually take the exam to gain entry.
Wow, yeah.
Just the entry exam.
Yeah.
That's a big
Just to
gamble,
take
isn't
the
it?
entrance exam. So,
That's a big, yeah.
and then it so happened that I got the admission,
Oh,
and the letter of admission came home,
yeah.
and I was preparing for my entrance exams in the uni library.
Yeah.
So when I came home, I just went, and then I saw the letter after about an hour when I opened it. I just jumped up and down. My dad had already opened the letter, and and he didn't even bother telling me because Dina, ophthalmology is second. You just gave it as a second choice. Why do you? I thought you wouldn't be interested.
Yeah.
But
wow.
that decision I made was probably the best decision I made.
Really?
If
I
I wouldn't even think back
Yeah.
doing anything else.
Ah.
All the negatives aside, I think the positives from the role as an ophthalmologist is great. And
Yeah.
to be honest, I was thinking, what was I thinking to become a cardiothoracic surgeon? That was my aim.
Was it?
Okay.
Wow.
Yes,
Cardiothoracic
yes.
surgeon?
Yeah.
Crazy?
Yeah.
But-
Gosh.
Yeah.
Ah.
But since then, ophthalmology has developed significantly.
Yeah.
When I was finishing my 3-year training, see in India how it works is you have a structured 3-year training, and at the end of it you get your postgraduate degree.
Yeah.
Okay. And interestingly, as part of that, you have to do a thesis.
Yes, yeah.
And my thesis was in wet AMD.
Yeah.
Can you believe it?
Okay,
Yeah.
right.
Wow.
That's
So-
where it started.
correct.
Yeah.
In those days, the macular photocoagulation study was there, and I more or less mimicked that study in the local unit, where you used laser to burn off the neovascular membrane,
Right, yeah.
and that was my thesis.
Right.
Um, The interesting observation after coming to this country is that in India, a lot of them had advanced AMD at a very earlier age, in the sense some of them were in their 50s and they would lose sight. There may be a bias in it because the unit I had trained in is the apex institution in the country. So a lot of people who could afford, they would come and get their treatment. So we would see the really advanced tumors, advanced pediatric conditions, pediatric cataracts. So they could cater for everything. And I'm yet to see certain conditions that I saw in India, because it used to be so advanced. But in those days, the treatment was such that you're achieving success from the treatment point of view, but the patient's point of view, not so much, because it left a scar in the middle, and you had a little area that you can't see, which is totally different to what we aim for now.
So
Yeah.
you still had those functional difficulties.
Yeah.
That's correct.
Yeah.
That's correct.
So the people are sort of saying, but I've come in for this operation and nothing's changed, I still can't see.
That's
And
correct, yeah.
Absolutely.
So
we-
that's
so
how the ophthalmology, I ended up being an ophthalmologist.
Wow, okay. Do you have a favourite operation to do?
I actually, it's not so much a favorite operation, but there are certain things which make dramatic difference to the people. One of them is cataract surgery, and you would find that you may find that even people with AMD and other macular conditions, sometimes you may think that they may not benefit, but then they haven't benefited objectively, but they are sometimes ecstatic, and then you say, "Oh, all these things are brilliant." The contrast.
Yes.
We've had that firsthand.
Yeah.
You've probably been responsible for some people coming in on cloud nine.
Yes.
The results have been dramatic. And
Correct.
It's,
The contrast and the
clarity
widening of the
and the-
field of vision and everything.
And the colours.
But sometimes you find the contrary.
yeah.
They would have got 6/5 vision, which is excellent,
Yeah.
but they are not satisfied.
No.
And obviously, I'm not talking about the people with macular
Yeah.
degeneration, but the other, they feel, I can't see all the distance because they have lost their accommodation ability to see the
Yes.
distance and near without needing glasses.
Yeah.
But I think that's one. The second thing which dramatically changed is treatment for AMD with injections into the eye. And I think you could see sometimes within a week, the distortion disappears and everything becomes dramatically different. And the people who appreciate this more are the people who have lost their first eye in the times when nothing was possible.
Right.
And the second eye, I think it's so amazing. And I think there are people who are coming for so many years still benefiting from the treatment.
So it's not about the operation success, it's about perspective, really. isn't it?
Correct. What you can do for the patient and how they see life through the newly acquired vision.
Absolutely.
So how do you feel that these operations have advanced in the last, say, 10 years or so, seeing it's speeding up now and getting exponential?
Correct.
So things like we can do cataract operations while still under treatment for wet AMD, is that something that's quite new as well?
If you go back at the time when I trained as an ophthalmologist, phaco was just coming in. So when I finished, at that time phaco was being introduced in India in my unit. It wasn't popular elsewhere.
Where you would do the cataract surgery,
Correct.
putting the new lens in.
Correct.
Yeah.
But at that time, residents or trainees, we were not allowed to do that. We were doing the standard large incision operation, where you have to, and then intraocular lens technology came in. So when I came to this country in 1990, at that time the technology for lenses were there, but then the type of lenses used was so different to what it is now. And these were lenses that went in through large incision. Phaco, we started learning the technique late 90s, mid to late 90s, slowly coming in. And then the lens technology improved. So previously, even though sometimes you may be able to do the operation with a 3mm incision, but you didn't have lenses small enough to go through that, so you have to make a bigger incision and put the lens in and then stitch them up. Then the lens technology came in where you just roll them into a little injector, and then it can go through that small incision and open out inside the eye.
Sounds like
So
an umbrella.
Correct.
Opening up.
So that means you could do surgery with, currently the smallest incision that in our unit is 1.8 millimeters. So you enter the eye, remove the cataract in 1.8 millimeters. Although you may have to extend the incision slightly, you can still put some lenses through that and inject. And the sutureless technology. I remember in 1990 when I started, I used to clock them in, admit the patients onto the ward. They used to stay on the ward for 3-4 days before they went home. So this was an inpatient procedure. Now they are in and out within a couple of hours. So yes, but the risks and are still the same.
Yeah.
It hasn't changed in the, many years. The technology has improved. It's become safer, and the rehabilitation is quicker. And so the cataract surgery technology is really from the operation part of it, where the machines have improved, made it much safer. Previously, the chamber, as we call them, where you enter into the eye, used to be going like a yo-yo up and down, so you cannot maintain, and that meant that there was not much of stability. But now the sensors sense the change in the pressure within the eye, and the fluid that goes into the eye will maintain the space.
Okay. Yes, yeah,
It's
yeah.
consistent, so you
Yes.
can concentrate on just the operation.
Yeah.
And then the size of the wound has gone down.
Yeah.
Correspondingly, in parallel, the lens technology improved, so you could put the lenses in,
Yes.
standard lenses in. Obviously, there are multiple varieties of lenses, multifocal, various types. But for standard cataract surgery, most people benefit from just what we call as monofocal lenses.
So that means that generally that lens would take up their distance prescription, and then the person would need reading glasses
or
afterwards.
intermediate ones.
Yeah.
But having said that, even in the monofocal lenses, some of them are called eye hands. There's another type of lens where you can get increased depth of focus. Younger people and people with more active life, even they may be elderly, they may benefit from that, even though they are not going down the multifocal or the other, what they call as premium lenses, for which they have to pay extra elsewhere. So in the NHS, these lenses are still available.
Can I ask a question?
Yeah, go ahead.
Just when you were talking about the sort of with the eye and doing the operation when the new procedures come in, did you practice? How do you practice? Did you practice before you go on a real eye? Do you what do you practice on?
I think yes. During the training days, even in the early years in this country, you do that because you do that to your ability. So your trainer will start off, because in those days the pig's eyes and the model eyes were not that easily available, so you would have to do them in real life. But then it's up to the trainer to pull you back up to a point where you can do, and so on. Obviously they train the same way. The trainers who, because there was no such models available. But lately with the technology of phaco, so when I started learning the small incision surgery, I went for 2 or 3 courses, and then workshops. I went to Croydon for that, workshops. You read a lot about the background. There were books written on the dynamics, a book called Phaco-Dynamics. So what it means is, what does that machine do when you put the probe into the eye? Okay. How does it maintain the pressure? There are different styles of taking the thing out, Some you have the negative pressure to pull things set up by the machine. Some others, it's by flow. That means the fluid that goes into the eye is the one which creates all the dynamics inside. So you have to learn all the basics of it. How does the phaco tip vibration break up? What are the risks? You do that. Then you do on model eyes, pig's eyes and others. When you do the workshops, that's where you do. And after that, you do that with the understanding that you will start them in small steps. One of the things that needs to be mastered before doing the small incision surgery is creating a circular opening on the front part of the lens, which is a bag. In the olden technique, you don't need to make that circular opening, and you just have to make a cut and then push the dense part of the lens out, and then you remove the rest of that using a probe. But then this is a totally different, unless you get that circular opening intact, you can't break the cataract up within that bag. Previously, the aim was to push it out, but now you have to keep it inside the bag. And that you can do in any standard, even the large incision operation. And then what you do is you get on with the rest of the operation as normal.
Yeah.
You make the opening bigger and then put the nucleus out. So it's a more or less like a step-by-step technique of operation, just replacing bits of your normal operation with what you need for your small incision, and then eventually you reach a point where you are able to do the small incision operations from start to finish. So that's how the training works.
Approach, isn't
Yeah.
it?
Correct.
I remember at the hospital there was a simulator.
Yes, I was going to come to that.
Yeah.
So now you don't even need eyes, you just need machines which will tell you, oh, you're too close to the front of the eye, you're doing... So these are what we call as simulators, IC, and you can actually practice in the simulator without even getting into the eye.
Yeah.
And the simulator will simulate for various operations.
Yes.
So ideally it gives you a score. It's like a video game.
Yes.
Yeah.
You know,
Yeah, I was thinking
yeah,
like
whether
that, yeah.
you just got killed and then you have to go back and start,
Respawn and
or,
It's like real life, you can't do it in real life,
That's
so you
correct.
get it right
Correct.
first in the game, yeah.
or you cracked your level 1 and then you go to level 2 and level 3 and so on. It's exactly the same methodology.
So could you
Yeah.
sort of, if you had a patient, say, who's got like advanced wet, like wet AMD, could you kind of program their like criteria into that machine to practice there before you went into the real operation?
The technique of cataract operation, whether it's wet AMD or patient with glaucoma or patient with diabetic retinopathy, is the same. It's the
Okay,
same.
okay.
The main priority there is, by doing the cataract operation, are you going to be giving them more probability of benefiting compared to the risk of harming them? It's just that you make. I'm sure you would have come across patients saying, "Oh, I was told that I'm not ready for the operation yet." It's not so much the cataract test; it's the eye itself. Because if you have wet AMD which hasn't been stabilized by injections, and they haven't gone through a time, maybe a few months, with stable disease, you go into the eye and do the operation. That's a major stress for the eye.
Yeah.
So sometimes people can develop a major bleed
Yes,
after a cataract operation, because when you go into the eye to remove the cataract, there's a lot of dynamics. There is a degree of disturbance within the eye, which itself can disturb the back part of the eye, and people can develop. The same thing applies to people with diabetic retinopathy. So if somebody had the advanced stage of diabetic retinopathy, you need to stabilize the back of the eye and get the laser treatment or injections, and then go and remove the cataract. If you do them too soon, once again the inflammatory factors released in the eye can actually make things worse in the back. In the a kind of analogy would be if a young person who's pregnant, who has diabetes, generally the obstetricians will tell them, stabilize your diabetes and then become pregnant, because pregnancy is a stress for diabetes. Then it can completely disturb the diabetic status and can make things worse. So in a way, that's exactly what we are trying to achieve when we are managing these patients. Sometimes it may be that they go too far out when they could have benefited by intervention 2-3 months earlier. But then, unfortunately, the setup in the NHS is such that you have to balance out and some people may miss out. And that is one thing. There's no science to it. If you look at the literature, there are studies which support one, and there are studies which support the other. Early intervention is good, delayed intervention is better. But I think it's the one-to-one conversation that you have with the patient.
It's got to be individualised, isn't it?
There are times when we intervene, because if somebody goes on with unstable AMD or diabetic retinopathy or diabetic macular edema, then there's no point in denying the benefit that the cataract may offer for too long. Because there may come a time when, what is the point in me having the operation if I can't have it now when I would benefit from that? So you discuss with them.
Once it's gone, the eye has still got the condition, so it's still going to be poor, isn't it?
So in those situations, what you do is have a one-to-one chat. There is a risk that things could get worse, but we can combine the treatment. We can see you sooner after the cataract surgery, and if necessary, we can top up. And we always try and make the wound secure by applying a stitch in case things got worse and you had to intervene before the wound stabilized. So then we can go in. There are times when, when I've done cataract surgery and put in a steroid implant in the eye because I know that their diabetic macular edema would get worse. So you preempt that and put that in, and then the recovery period becomes a little less turbulent, shall we say? And that is something that you have to.
It's interesting though, because the eyes it just shows that how much the eyes are part of the whole system, isn't it? And how something like diabetes has such an impact on our vision and our eyes that sometimes people don't always relate the two, do they?
No, that's absolutely true. I think obviously we are talking about the major conditions like AMD, diabetic retinopathy, retinal vein occlusion, where the two major groups of conditions like diabetes and blood pressure come in, high cholesterol. But there are a vast variety of other conditions which affect the eye, infections, inflammations. So you need to have knowledge about general medicine, neurology and others to be an ophthalmologist, and you find a lot of times that sometimes people who are non-ophthalmologists may deal with a respiratory condition, a nephrological condition, an endocrinological condition. When they come to us, you think they are individually dealt with, but they are all part of the same. And when you look into the eye, you think, do you have this? Do you have this? Do you have this? And sometimes it may be too late before they come to us. Then you can put the jigsaw puzzle together and think all of them is this one condition affecting 3 or 4 conditions, and it's an inflammatory condition, life-threatening, sight-threatening. I can remember a lady who came with her employee. The employer was a younger person, and this lady, she came with him. So I got the call from one of the other junior doctors. I've got this patient. I was at Bassetlaw, and I said, hang on to her, I'll come. So we saw the patient later in the evening. I could still visualize seeing her. And she has lost hearing, which was thought to be, at the time, there's sometimes we all have this assumptions, don't we, that something that happened is always been the case with the person. Examine the eyes, and then something occurred to me. Then I said, how long have you been like this? Have you always... The employer who came with her as a friend, she said, no, she's been having this only for the last 6 to 8 weeks. She could hear, but now she can't even communicate with her because she can't hear. Then have you had any other problem? Yeah, I went to another department and I was inpatient. I was treated because I brought up blood when I coughed. Then have you had any other problem? So it transpired that at that moment I thought, she's lost vision in one eye. We've got a condition which possibly needs to be ruled out, which could be life-threatening. She could develop other conditions. So everything kick-started. We referred her to nephrology. They did a biopsy. The condition was diagnosed. It's called Wegener's granulomatosis, which affects the respiratory system, kidneys, eyes, hearing, everything put together. And we admitted her onto the ward, gave her high-dose steroid, and then I saw her the next day. With 1 dose of steroid, her hearing improved completely. Previously, then she could hear everything. And she still comes. Unfortunately, she lost one eye. That's when she came to us. If she hadn't had that, we don't know. It's only theoretical how long she could have gone without. And I think that's one of the things that ophthalmologists, and I know maybe other specialists would also say the same, but as ophthalmologists we try and put them together. A lot of, correct.
Yeah, absolutely.
Nikki may be aware that during you just think, is this put together? Sometimes you may end up spending 45 minutes to an hour with one patient, and that means your rest of the clinic gets out. But most patients are, most people who come, they do know that some of the conditions need longer time, and they are very flexible and they are understanding. And that evening, for my visit from Bassetlaw to hang on to the patient, may have been different if
Yeah.
the patient was sent off with whatever, and because the suspicion was it was a blocked artery that caused the vision loss in that eye.
Oh, well, yeah.
But then the extended discussion and the support from the friend and the employer and the probing changed the whole perspective for that patient, from something where you could say, I can't do anything, and you send them off, to something that you could do something on that day, that evening, and save that person's other eyesight and also, in a way, life.
So I think that, you know, for us as patients, we won't necessarily know to make that connection.
Absolutely.
So it's like we've spoken before about advocating, being your best advocate. So that's one of the things, you know, you might think that like, for example, it might be a bit of a silly analogy, but the swelling in your big toe and the throbbing and the heat's got nothing to do with your eyes, but it might have, you know.
Absolutely.
Tell the doctor everything.
Absolutely. You know, sometimes, I do ask them questions saying that you may think that it's totally irrelevant, but then is there anything else that's been happening that you may want to bring it to my attention? You may think it's unrelated, but I may be able to link them together. Sometimes, you know, nowadays we get infective diseases, younger people coming with sexually transmitted diseases and things like that. So you may have to sort of preempt the question by saying that I may ask you certain things which you may find it, and then put together, because that could eventually be the life-saving question. Because we have come across younger patients with conditions presenting with the eyes, but then you have to ask these questions and then direct them to the and that short 1 week, 2 week course of treatment is going to be life-saving, prevent them from developing certain disability and so on. And I think that's the thing. I think that's one of the things as ophthalmologists, because we are not surgeons. We spend 80 to 90% of our time in dealing with patients. We are physicians who do operations. And the physician part of it is you're a general medical physician dealing with blood pressure, high cholesterol, diabetes, endocrinologist dealing with thyroid eye disease and things like that. You're a neurologist dealing with patients who present with multiple sclerosis, other eye conditions which have the neurology background. So you do need to make sure that you have got the background. And the other major group is infectious and inflammatory eye conditions. So you need to get the rheumatologist coming in and say, you need, and there are patients with giant cell arthritis, one of the conditions they present to us, but then it's not an eye condition, it's a general health condition, inflaming all the blood vessels, presenting through the eyes, but they'll be looked after by the rheumatologist for a long time to come. But it's just that connection to be made. Sometimes it makes so much difficult to distinguish, are we dealing with this or not? And you have to make that
blurred lines, isn't
correct.
it?
Sometimes.
And I think that's our kind of takeaway. Certainly what I'm taking away from this is just really helping people understand that nothing is a small thing. That actually, just say everything. And that you maybe ask questions that might feel a little bit disconnected when you're being asked them and uncomfortable to answer. But actually that answer could be part of a bigger puzzle that can really help the doctors put together a kind of idea of what's going on and what treatment might be needed. It's so important, isn't it?
Yeah, unfortunately in the current environment where there's so much pressure on time and the numbers and everything, you do need to dissociate yourself from that pressure when you have the person sat across you, and then you need, this person is going to take 3/4 of an hour, maybe an hour, but unfortunately you need to devote that time for that person to put the puzzle together. And then obviously that may delay the rest of the people in the clinic, but certainly that's when you communicate with them and make them aware that not everybody is, somebody can be dealt with within that 10 minutes allocated for their time.
They're not all
No.
straightforward,
No.
no.
And if that time is not allocated, that particular patient may not get the best out of that consultation. So that's important.
It can be life or death for some people.
Yeah,
I mean,
yeah.
that example you gave, Dina, is just it's frightening, the thought of what could have
Absolutely.
happened.
Yeah,
I remember
absolutely.
that person's name very
I
well.
bet you had sleepless nights when you went
Yes, I remember the name.
Crochet,
I can
yeah.
still visualize
Yeah.
where I saw.
Yeah.
There are
Really
like
stick
certain
with you,
things,
don't they?
yeah. It's interesting that we talked about visualization. I still can remember as a trainee doctor in Delhi seeing a 3-year-old girl where I unfortunately had to tell the mom and the dad that she has features of retinal disease that is going to impair her life, and she was, and I can still visualize her, how she looked, and the room where I examined her. But these are things that's
Sticks with you.
Yeah.
correct,
Yeah.
and I
career,
think
doesn't it, as
correct,
well,
and
yeah.
I think I believe at that time, as you rightly said earlier on, certain things come with you. It cannot be taught.
Yes.
Yeah.
Yeah.
That empathy and
yes.
that time that you have to give, because as trainees we had the time that we can allocate. Even though we can allocate it, we can always, because we always shared the clinic in that unit where 4 or 5 junior doctors with 1 consultant. So you could take the time that you want, and then you go and present your case to the consultant, and then you come back and talk.
Yeah.
Things may be different, but probably not as different as I think it should be. That empathy training, even though we talk about it, but I think the curriculum is still not designed for that. That breaking the bad news. We go through courses and things like that, but I think some of it comes from within you.
Some of it's you.
It is,
has
isn't
to be.
it?
It has to be.
A lot
has
of it
to.
actually is that
Yeah.
untaught
It has to be.
way that you
Yeah.
might have to communicate.
You can get tips from going through these courses and things like that, but if it comes without that heart being put into it,
Yeah.
it won't come across well to the
Robotic,
patient.
isn't
Yeah.
it? Yeah.
Yeah.
It won't be a comfort to
And I
anybody.
think
will
as
it? Yeah.
patients, when you're on the receiving end of an emphatic doctor giving you that news, it just makes such a difference. And we've seen patients where the opposite has happened, and it's traumatic. That trauma of that sort of very blunt. I remember one gentleman coming in saying he drove to the clinic, and the consultant said to him, "How did you get here today?" And he said, "Well, I drove." And he said to him, "Well, you're not driving home." And as
Without the way to break the diagnosis
Wasn't
in a way, yeah. It's like,
and he was a guy in his 50s. He was still working age. He needed. It was just devastating, So
That's absolutely true. I think it's also important for us to be evaluated and trained and observed and criticized on the way we communicate. I think communication is everything. You can say the same thing, mean the same thing, but the words make such big difference. As we were talking about earlier on about the words that you use, and breaking it, giving time for people to understand, and then probably even allocate, if you're pressed for time, people in the clinic who can take them over for a cup of tea and then have a chat, and you can see the difference in the way they perceive. If you give the time, I've been in my own situations similar to this, and when you go with a relative or something for a consultation, and then something is, some people do it much better than some others.
me too.
Some others, they take the time, and I recently have been with one of the family member, and some others, they just do it. There's nothing wrong. They are just saying.
They're saying it's what it is.
Yeah, they're just.
These are the facts, and this is what
Correct.
it is.
They have not done anything wrong in giving the diagnosis or making you aware of what it is, but it's the time taken and the delivery and the words used and the attitude and the sympathetic attitude that they. Yeah, I think we need a lot in in the medical field, if not every field, but I think we need a lot more.
Across the board, isn't it? I think there's also an element of what the patient hears as well, what you know you hear as a person. So I'm trying to think of an example. It might be like, you know, sometimes people will say, oh, you've got AMD, you're going to go, you know, you'll be, you know, they relate AMD to sort of like blindness, or you're going to lose your vision, whereas people think that means like black, blind, cannot see anything at all, when that's not actually the case if it's just AMD,
Correct.
isn't it? Yeah.
I think a lot of people, you know, when I first started, you know, during my medical, not medical school, my ophthalmology training, the condition AMD was used to be called, I'm sure you're all aware of it, used to be called SMD, that senile macular degeneration. That was the very first term for this condition. Many people nowadays may not be aware that was the case.
Language
I didn't know
evolves,
that.
isn't
So
it?
that got changed to age-related macular degeneration, which is a lot more acceptable, yeah. And similarly, you know, a lot of situations, it's the same condition, but then the perception. So there's no real reason to use the word blind, because severely sight impaired expresses that you know, status much better than blind, because most of us, you know, when we say blind, blind is blind. Okay? And I think this is where the society may also perceive people who are registered blind in quotation marks. So severely sight impaired may be more acceptable to society. When they see somebody, you know, if somebody says, I'm registered blind, you know, you're registered blind, but then they are able to do certain things. That disconnect between the word and the reality is confusing. So I think that's where you know, we and you guys are doing a good job in that sense, and we have to probably be in that. So that's why very rarely would you use the word blind unless somebody's literally blind, which we do come across. But that is rare.
It's only 5% of people registered severely sight impaired have no vision at all. It's a number of about 40,000 people probably in the UK, so it is a smaller number, isn't it?
Correct.
Something like that. I haven't got the exact numbers there, but But in terms of language and interacting with people, it must have quite a toll on the actual professionals like yourself as well, though. It's a lot of giving bad news, so there's a bit could cause a bit of issues there, maybe.
True. You know, having said, you know, like I said, you know, some of these situations stay with you, but then they also mold you to become the better person. And I think sometimes you do go home and you go into a spell in your zone of your own, if you have come across. And I think sometimes you do need a supportive family to be able to understand that you've had a tough day, not so much demanding physically, but emotionally and mentally. I can even still narrate to some of the people during my house officer days. In those days, one-to-one nursing care was not that easily available. So the doctors, who were the house officers, were, basically, if you imagine in a coronary care unit, one nurse is allocated to a person, maybe less frequent now, but then they look after that person for 24 hours. So we used to have a terminology called bedside duty. So a house officer was given a bedside duty for a critically ill patient. And I still remember the name and visualize the place where we were doing that bedside duty, me and another house officer, a lady who had, unfortunately, incurable leukemia. I'm talking about 84, 85. I literally had to watch her pass away in front of our eyes. And those kind of things come through to you because that's a traumatic event, but somehow got through, and unfortunately the treatment available did not allow her to survive, but things are a lot different. So you have to think back on those days, and you survived those, and I think sometimes, like the 3-year-old girl that I said, this young person, and the other lady where you've done the opposite, you've made things better. So sometimes they balance out, and you think that not everything is doom and gloom. That
Yeah.
you can make things
Made a
different to
difference.
I think it's
people.
important to know because we get a lot of people that forget that the medical professionals are human as well.
A human as well, yeah.
True.
Yeah.
You're absolutely
You're
right.
not just a
I
robot
think.
that fixes. And
Absolutely.
Yeah.
Correct. I think
absolutely.
you, I think probably nowadays it's understood and many people are aware that, but still it doesn't excuse somebody who's taken up the profession to behave in a different way that somebody else may do. So you do need to, having entered the profession, I think we have a responsibility that we conduct ourselves as best as possible.
Yeah.
And if somebody, if we need time, we can excuse ourselves for a few minutes, just go away, and then come back refreshed in your mind that to deal with that situation better. I think.
So as consultants, do you have like access to mental health support?
Yes.
For you?
Yes.
Yeah.
Our trust, well-being, pretty much every trust has that, and I think. But the point is, do we access that?
Do you access
It's about, do you recognise when you need
Correct.
to
Correct.
do that, isn't it?
Correct, and that's the point. And I think one is time pressure. The other thing is you probably want to carry on doing things, but it's I do know not immediate colleagues or anybody, but many people who have access care and they have benefited, and nursing staff, they do have access, self-refer, and then you have access. It's important that such a thing is available.
It's a high stress environment, actually.
Correct.
Isn't it?
Possible.
Yeah.
Because demands now is high, expectations are very high, and I think what is out in the social media is not reflecting the reality, because I think everything is
Perspective.
also put across as completely positive. So you need to be able to deal with the negatives as well. And I think
I think the thing is as well, hospitals naturally are anxiety inducing, aren't they?
Yeah.
Patients are not visiting because they feel brilliant.
Yeah.
They're visiting the hospital because there's a problem.
Yeah.
And I think while some of those problems might be, quite low level, for the clinician, might be bread and butter, but for the patient, it's the worst thing in the world that's happening to them. And I think that for clinicians dealing with that anxiety, even if it's in their mind not totally necessary, they've got to then find a way to help bring the patient, down from that. And that's carrying that patient after patient. I mean, I know obviously from working with you, Dina, and how heavy the clinics can be, just numbers, volume,
yes.
And then emergencies on top of that. Sometimes they can get very, very busy, and to kind of have that back to back, it's a lot for the whole clinics are like a pressure cooker sometimes, aren't they?
Yeah.
And you're dealing with a lot of feelings.
Yeah.
And I think one of the other things is you need to seek the relevant people to help out. Sometimes we are not fully qualified or trained to do that. One of the areas where it would be perceived as sensitive and can be, if it's not addressed properly, like weight loss. There are certain conditions, we have a lot of younger people presenting with a condition which optometrists pick up, optic disc edema, and some of them can be due to buildup of pressure within the brain, which causes that swelling. And one of the things that would help is weight loss.
Okay.
But to address that to a youngster, you have to balance it out right, because you don't want to be able to push them to the other side.
Yes.
And at that balance, even pediatricians, I'm sure they would find it. So you need to address that sensitively, and we may not be the right people to be able to do that.
Yeah,
so you may have to say, do you want to address that and things like that. You may have to put it in a very neutral way, not non-accusatory, because it could be perceived like that, although it is going to be beneficial, but you don't want to do that in such a way that it could be detrimental.
Yeah.
Yeah.
And that
Yes.
balance is the one
Yeah.
which is difficult
Yeah.
to
Tightrope,
achieve.
isn't it? Not to cause harm, though, isn't
Absolutely.
it?
And it's difficult when you've only got a certain amount of time to see with that
Correct,
person. It
correct.
might be the first time you've seen them, although it might all be in the notes, but you don't have time to read the notes
Correct,
always, I would
True,
imagine.
true.
So I still goes, for me, it always goes back to you've got to be your own best advocate, isn't it, when you're there in the
True.
hospital, in those appointments.
And sometimes a neutral, question like, is there anything else you want to bring up? Because sometimes if you carry on directing the questions to find out, just from the diagnosis point of view, there may be something else. And I think relatives or somebody who's next door, is there anything you want to bring up? Because sometimes the patients will reveal to them things which we don't. We come across this very often. Patients will be sat in front of you, but they'll be talking to the healthcare assistant stood next to them or sat next to them, because they feel more connected to them. And that may be the case with the relative or the carer who comes along.
Clinicians can be intimidating.
Absolutely true. Although things are different now,
Yeah.
in the days when I trained, to go knock on the door and enter into the consultant's room to ask for an opinion, that means we have to think so much before. Am I allowed to go in to ask? Right?
Yeah.
But now I have an open door policy, more or less, in the sense
I
that
think
anybody.
some patients, and in particular, if we think of the age demographic of sort of macular degeneration, you have got that sort of more older school that go in and kind of maybe meekly sit in front of the doctor.
Yes.
There's that
Occasionally.
that kind of dynamic that you
Mm.
still see, which hopefully is going to change and keep changing. But it's still there a little bit, isn't it?
I know that Anita, you nearly get blue lighted every time you get your blood pressure taken at the doctor's, don't you?
I do. I have white coat syndrome, so every time someone puts blood pressure cuff comes anywhere near me, and the doctor is like, but when we were talking just now, I was thinking about you were saying about sort of things that don't get said, but Charles Bonnet syndrome. We were talking earlier, weren't we, about that, about how. Charles Bonnet.
It's amazing, sometimes, I was telling Anita about actually a healthcare assistant who just in passing mentioned she was, I think, she was under our care, or maybe her vision was too bad that she couldn't be treated, or otherwise she just said, I've been asking my mum to do this, go and speak to the GP and get some help. And she just expanded on to say, she's seeing all these things. Does she have visual disturbance? She said, yeah, she was diagnosed with AMD and she has very poor vision. I go and see her every evening. And she just opened out. She said that she's seeing something in front of the window. There's nothing there. She said there are two birds sat on that tree and there's nothing there, Mum. Then I said, bring her over, get her booked into my clinic. I can explain, and you can come with her, and then we can have a chat. So got her in, and then we had a chat. She has been suffering this for months, but she was hesitating to tell to her daughter in case something more serious is done for her. She's sent to a care home or something like that. And that conversation, just passing, made such a big difference. And it's not unusual for relatives to mention, Dad was saying that he could see people marching in front of the window, or he could see a nice forest in front with so many birds sat there far in the distance. There's nothing there, Mr. Dinakaran. I said, no, let's address that. I don't think we proactively ask for that, but whether it is right or wrong, I don't know. But I think it's something that we need to address then, because that's reassurance, saying that they are not imagining. It's just that the brain is doing something, putting sense to what they see in appropriately is what the reality is, and the vast majority do fade away over time. But that distinction between, am I going to be named as somebody with mental illness to something which is theoretically explained by what the brain does as wrong interpretation of the signals that the eye is sending to the brain.
It's
that
fascinating,
that
isn't
kind
it?
of reassurance, both for the family and for the person,
Yes.
because that you can see the sense of relief from both
Yes,
people.
yes,
Yeah.
yeah,
And,
yeah.
and here is the daughter thinking, oh, am I going to put her in the care home? And what is she? Okay. And then the mum thinking, will she take it further and put me? That connection,
Yeah.
and then everything falls into place.
Knowledge is power, isn't it? We actually had a Charles Bonnet information warning
We did
recently because a lot of our people felt they wanted that community with other people who were experiencing it. So everyone was sharing their Charlies, as we call them, around the table. It got quite interesting, didn't it?
Obviously, not all of them would want to come into a group.
No.
So there is still that cohort of group of people who want to have that reassurance and the one-to-one, because they don't feel comfortable even in a group of this patients with the same condition. It's like like everything else, it's individualized care, isn't it? Unfortunately, the system is not designed for that, but we have to make the system work for such people as well as the people who can just walk in and take the information and go.
Yeah,
That's great.
That's fantastic. You've been so open. It's been we've got a list of questions here, and actually, I don't think we need to ask any of them because you've just been so open talking about your experiences.
It's been fantastic.
Isn't it?
Yeah. No, I think it was always left to say thank you, Dean.
No, that's wonderful.
I want to carry on
nice.
for.
Yeah.
I've got 15 hours battery life from these. So.
But also, you the people who log into it should be able to hear the whole of it. They may not have the time.
Well, you might have to pause and go for a break, but that's fine, no problem. But no, Dina, I can't.
I don't know. I think one thing that might be helpful, though, because we do get this question quite a lot, if it's okay, is just around virtual clinics. We still do get a lot of kind of patients asking about what that is, what it means for them, and not seeing a doctor and that. So to hear it from you would be
I'm glad you mentioned that. I think probably towards the end of this, maybe 2 or 3 minutes, I'll just touch on 2 or 3 aspects of it. The virtual clinic, which you brought up, which is good. Now, when I started in 2003 as a consultant, even though I worked since 1990 training, I was the first medical retina consultant with medical retina interest appointed, and I was solo. So that means other people were caring for patients with diabetic retinopathy and others. And at that time, the treatment for AMD was coming through, photodynamic therapy and so on. 2007, 2008, that's when we had the first major breakthrough in Lucentis. When I started, I enlisted a colleague of mine who was not a medical retina person but had some experience, because I didn't want to do everything on my own. I needed a backup, and we two started. I remember 6th of October 2008 was my first injection list.
Wow.
Six patients in that list, because we understood. It was thought at the time that we will not play a role and all patients will be cared for in teaching hospitals. But I knew that that would not be the case. So I had to get the OCT. The first OCT took 2 years from me asking for a business case to actual delivery.
Wow.
But then that was required for us to evaluate the patients. So what it meant was that there came a time when I was doing general clinics, I was doing pediatric clinics, I was doing refractions for kids and giving glasses. All of this was part of my day-to-day life as an ophthalmologist. So we had to devise a way very early on I can't remember the exact time when I had to make it virtual. The advantage of the virtual clinic is that all the necessary information is collected for a consultant-led opinion to be. We have still kept it as consultant-led opinion. Mm-hmm. There are many units in the country where it may not be consultant-led, but we have kept that, whether right or wrong, we kept that ethos going. So the decision-making on the images collected is by a consultant. The reason why it was done is, with one session, it doubles the capacity to twice. So that means you can allow some patients who are waiting to enter into the system. So we could allow them to come in, have their first visit within 1 to 2 weeks, depending upon their needs, and overall benefit of that. So that's why it's virtual. Until recently, the letters were not saying that, so many people did not know. I believe I raised it, and I think it's more than a year now. I'm hoping that it's gone through. If not, I'll chase it up. That it should say in clear terms that they will not be seeing a doctor, but it will be interpreted in a letter from the doctor. So that's about the virtual clinic. The other aspect you would find in the general care is, what you mentioned about when will they see a consultant. We aim to bring them to see a doctor in at least once a year. Okay. That is
might have virtual,
and then they'll come back.
Yeah.
But that's in a standard pathway.
Yeah.
But if anybody has something which changes, either the other eye is affected as we review, or the same eye not responding, we need to modify the treatment, then we will bring them back. So if there is no change and they are doing well, their aim is to bring, or suddenly they raise the question, when will I have my cataract operation? Then you bring them back. So these are things which will be dealt with by query. So the people who are listening to this podcast is, if anybody who is part of the virtual clinic and if they have any specific concerns, if they raise it with the healthcare professional whom they come across, either the photographer or the healthcare assistant or the nurse who sees them, that will be documented in the system, and then the person who's reviewing the images will have that question. So they will address that question. And if they felt that that question is significant enough for them to be brought back for, sometimes when you come across this code, I've not seen a doctor for a long time, you review that, yes, they had gone past that 1 year mark. So then you say...
The common one I remember was, I really want to get some glasses. Can I get some glasses yet? So I would always put a little note in.
Correct.
Can you advise whether they can get some?
Correct. And then when we write back to them, we'll say, yes, you're okay to see your optician for your glasses or otherwise. The other thing that I want to point out about AMD and things which, because it's really AMD where things can go overnight, whereas diabetes and retinal vein occlusion can also be the same. But AMD, the earlier you start the treatment, the better the prognosis is. And that means people who don't have wet AMD in either of their eyes, they need to identify the first eye quickly enough. This is one of the things that we find that we don't do that.
No.
We don't cover one eye and the other. I won't go into go details, but someone had been in that situation, and then we realized too late. So that's one of the things. You don't need the Amsler chart or anything. Just find something which has got a straight line. Vertical blinds are ideal.
The tiles in your bathroom. You've got tiles in the bathroom.
Vertical, the blinds. Or I usually say, if you have a mirror which has a rectangle, horizontal and a vertical light, cover one eye and the other. Just see what you appreciate. That would be one way of identifying. Many people come to us when they have had their one eye done, and sometimes patients who are under our own care have not picked up changes in the other eye, and then we think, bring them back and then start the treatment. That's one of the important things.
What would be the initial changes people need to look out for then?
Distortion. A straight line appears distorted, and I think, or the face that you look at distorted. Things which you saw, a clock face, when you wake up, and most of the time, I can see my clock. Sometimes people say the positive side. I know it was all over. Now that I've had the treatment, I can see the clock. So something like that, with each eye covered up, would identify early. Then the best way to get to us is first optometrist who's available, get them, because pretty much everybody has an OCT and a fundus camera that they can capture. The reason why we want that as the screening tool is because a lot of people may have the symptoms, but not everybody would have wet AMD. So then we want to, out of 10 referrals, maybe 3 or 4 are the ones which are true wet AMDs. So we need to prioritize our resource to bring them within that 1 week to 2 weeks, treat them for those 3 who need that, and the 7 can come in, but they are not as time intensive as the 3. So to prioritize the limited resources. So those are the 2 ways. And pretty much all optometrists now have OCT, and that will be our screening
So
tool.
the advice is get a regular eye test as well. I know because a lot of our patients also, they might have had AMD and then they've not been seeing an optician for years, which is why we have our sight test facility, because even though you might have outgrown glasses, it's still important to have that regular monitoring, isn't it, at an optician's.
Because we can, in the face-to-face clinic, we can evaluate for glaucoma, cataract. Some people may have diabetes and others. So what we tell them is, people who are in this virtual clinic pathway, keep all your other eye care by the relevant people. If you have diabetic eye screening, attend that. If you have optometrist visit, attend that. Because sometimes things in between, if they are developing, then these people can pick them up and bring it to our attention.
Absolutely. Quick question, do you see AI being a useful tool in the future in terms of, reviewing the scans? Or
yes, already AI has been introduced in Scotland for diabetic retinopathy screening to identify the dots and the hemorrhages and then identify. AI already plays in a silent way in a lot of areas but in real life, AI directly getting involved probably will come in. At this point in time, it's probably not. So we are even struggling to give the basic care, but the AI role is going to be there in certain image identification.
Human oversight, obviously.
Correct. And I think the technology is developing and becoming a lot more accurate as well. Home
patterns, isn't it?
and home monitoring and things like that, and those are the things that we would see the future developments.
Just for the sake of our podcast listeners, could we just have a brief explanation between the difference of dry AMD and wet AMD?
Okay. So AMD is an age-related disease, as the term can take, and anybody over the age of 50, 60, 70 and 80 will have a significant proportion of them developing the age-related changes. Anybody over 80 will have significant changes that one would identify as age-related macular degeneration. So the most common macular degeneration is the dry AMD, because pretty much all of us will have that as part of their eye. So 80 to 90% of the AMD will be the dry AMD. About 10 to 20, depending variable proportions in different groups of people, will be the wet AMD. The visual impairment is the reverse. The vast majority of people with wet AMD are the ones who are severely impaired from vision, and the dry AMD part of it, as it advances, it can happen. But what we need to also keep in mind is that dry AMD is also visually impairing disease, and there are people who can even have, unfortunately, advanced changes due to dry AMD. And dry AMD can even present with visual symptoms similar to wet AMD, distortion. That's because it's just the retinal structure. Dry AMD, the retina thins out. In wet AMD, at the initial stages, the retina thickens. And both of them can cause distortion. It's like, a valley versus a mountain. They both can cause distortion of the images. But these evaluation techniques that we have will give us the information between the two. One of the things that people may want to know is, can we treat dry AMD?
Yeah, that is a big question.
There are a couple of agents which is also delivered by injections. One of them has been rejected by the agency, the MHRA in this country. The other one is being evaluated, but 2 licensed drugs are available. The difficulty with NICE and MHRA is that they always look at it benefit versus risks, and we also do that. There is a potential risk of treating dry AMD and turning a proportion of the people by the fact that you're treating them into wet AMD.
Yeah.
And the dry AMD trials did not evaluate the visual benefit.
Okay.
It evaluated the progression of the condition, but not put that link to the visual impairment. So that is why it may be difficult. It slows down the progression of the dry AMD and the areas where the retina is thinned out, the injections, and a small, probably about 5 to 12% varying upon a different time period, may be turning the dry into wet. And are we going to make people benefit visually by treating the dry AMD? Unfortunately, that link is not there. And that's why there's a bit of reservation on one drug. And the other drug is going to be evaluated probably by the end of the year. We'll get to know whether that will be approved. So predominantly, the treatment is focus on the wet AMD, early diagnosis, early treatment, and long-term. And from 2008, there are still some patients who are coming and having injections, and that wouldn't have been possible before that.
What's your opinion on the photobiomodulation treatment for dry AMD? So
Correct. A lot of trials have happened. There were times when people were being treated for drusen, which is the debris collection. Currently, the jury is out. Jury is out. And what we need to look at is the benefit more than risks? And that is what, as clinicians, that's why we look at the overall evidence and the randomized trials to find out. So we never know what the future brings. But as it stands, the treatment modalities which are effective are the ones that we are already delivering.
Can I ask in terms of, so lifestyle, what lifestyle advice would you give to...
Actually, it's a very important aspect of things which we probably not address a lot during our consultations. The first thing I ask somebody with wet AMD is that do they smoke? If at all there is one big risk factor that can reduce the risk pretty much on the day they stop, is stopping smoking. And it can also reduce the risk of the other eye converting to wet.
Wow.
Yeah.
Gosh.
So
I didn't
that's a
know
big
That would
risk.
go out from the
That-
day they stop.
Correct. Yeah,
Wow.
that's a big
That's
risk
an
factor.
incentive to,
Yeah.
So
And
it's about the blood vessels constricting, is it, when you have this?
yes, I think there are various ways. It's basically the chemical way of it working. The antioxidants and the oxidative damage that it gives to the, not just in the eye, smoking causes the
Yes,
same
it's
kind of
body.
damage
Yeah.
elsewhere.
Yeah,
So
absolutely.
that's number one. The second thing is other controllable risk factors, blood pressure, cholesterol. Those are things which are modifiable risk factors. Obviously, genetics is one of the risk factors. A proportion of people with wet AMD will have other members of the family affected, but that you can't control. Unfortunately, age one can't control.
Yes, yeah.
But if they direct these onto the modifiable risk factors, the other question one may raise is about vitamin supplements.
Yeah,
And these are specifically designed vitamin supplements. There are multiple varieties of them, but the evidence base is on a certain group of vitamins which were tried out over multi-center trials running into years. Age-related eye disease study, the first study, and then the second study. And those supplements are known to benefit a proportion of people who have a certain level of dry changes or reducing the risk in the fellow eye with wet AMD. But in the eye where there is wet AMD, these vitamin supplements don't do anything. They do not have any significant benefit. The benefit comes from early diagnosis, early treatment, and regular monitoring and top-up treatment as and when required. But if they are on the what called the intermediate dry AMD stage, or in the fellow eye, the vitamin supplements help. But like everything else, fresh green vegetables, fruits, they always will form part of a
Yeah.
good lifestyle.
Yeah. So kale, broccoli, spinach.
Absolutely, absolutely.
All the stuff your mother told you to eat when you were a kid and
Absolutely.
you didn't. You hid
Correct.
under the plate.
Correct. All of those would help.
Mm.
But certainly there's a role for vitamin supplements of the correct combination,
Mhm.
and smoking if they can't. It's difficult, but then the benefits are definitely proven
Yes,
Mm.
yeah,
from the day they stop. Yeah.
absolutely. Fantastic. Gosh.
This has been
Learned so
my
much.
favourite
I
session.
know, me too. It's been really, really interesting.
Wonderful.
Thank you
Yeah,
so
we'll have to,
much.
we haven't
Thank
hit
you.
quite everything. We'll have to invite you back
We'll have to
sometime.
invite you back.
No problem. No
Part
problem.
two.
Part
Watch
two.
this space.
It's been a pleasure. It's been a pleasure. Obviously, we have covered the one aspect of retinal disease. There are, there's a huge
Oh,
We'd love to
diabetic
have you back
retinopathy,
to
retinal
talk
vein
about that.
occlusion, and others,
Yeah.
where thankfully we are able to help them. But there's a big area of our practice which does come into picture. Yeah.
Yeah.
fantastic. Thank you very much.
Yes, Gina,
Thank
thank you
you.
so much.
Thank you.
It's a pleasure. It's a pleasure. I hope people who listen to this do benefit from the
I think
discussion.
they will.
I think they will. I think they'll be asking us to have you back.
A huge thank you there to Mr. Dinakaran for joining us. If you'd like to know more about the work that the Partially Sighted Society does, please give us a call Monday to Friday, 9:30am till 4pm on 01302 965 195. The Partially Sighted Society is a registered charity. Charity number 254052. Their address is the Partially Sighted Society, 1 Bennett Thorpe, Doncaster, DN2 6AA. And that contact number again is 01302 965 195. Thank you very much for joining us again for this PSS podcast. See you again soon.